Right then. Sorry, right, just get over this technical problem I had. So back to sweating the assets, so kind of deep diving into kind of what this really means. So it's kind of about looking at our practice issues within the BSOTS. What's the reality of this, and how do we overcome our problems? And looking at kind of data from patient waiting times when the ACP is in triage. Can it really have that desired impact to improve that patient flow and reduce those serious incidents in triage? We'll talk a little bit about kind of what happened prior to kind of the ACP being put in, but also from BSOTS as well being admitted. So it's about kind of looking at the two tools together in terms of how we can improve our patient outcomes. And also, I've added in here what the staff that I'm working with think about the ACP role and what they think the impact has had in triage when we first set up this role 18 months ago, and we are just doing the same survey again, kind of 18 months on the line to see how it's embedded and how how it's impacting them in triage now, how they feel that role has continued. Has it continued to be as beneficial as they thought it would be, or have they seen any problems within it? So we're waiting for that feedback. So hopefully we'll be able to share that with you on a future forum. But that's kind of an upcoming thing. So it's quite an exciting thing to be able to kind of produce for you today. So just kind of reiterating kind of some of the information about my particular triage, and obviously every triage is very different. Obviously we have our 5,000 births a year. We do see between 30 and 50 patients a day on triage, so it can be quite a busy little area that we have. And every kind of triage kind of ward is very different in terms of how we have one triage room that we see people to triage and that initial assessment, and then we have our 3 ongoing assessment rooms. So they're very busy in terms of a kind of hotbed situation, but they are individualized rooms. They're not kind of in a bay. Prior to CQC, we had 2 midwives on each shift from 7 a.m. to 1:30 a.m. It was not a 24-hour service. We had no designated doctor and only had the on-call SHO and SPR who were on call for the whole maternity unit, not just for us. We did have our set times to meet, our 15-minute initial review for the triage as BSOTS set standards, and we had our red, amber, yellow and green review timings, which we've discussed before in terms of those reviews. Prior to the CQC and our data pre-BSOTS, we had 5 serious incidents from inadequate initial triage processes prior to kind of BSOTS coming through. What we used to have is women just turning up to the door, knocking the door and presenting. We put the name on the board and there was no particular order. It didn't really matter what they were coming in with in terms of conditions. They would get seen in presentation order rather than in terms of need. We had 5 serious incidents from this inadequate initial triage process. From delay in care, incidents range from stillbirth to also sepsis, and quite nasty sepsis at that. There was 1 serious instance since the introduction of BSOTS from a patient not being effectively triaged, but this was outside that triage working hours, so it was between 1:30 a.m. and 7 a.m. And it was seen on a different area who didn't undertake the BSOTS particular review and therefore wasn't effectively triaged properly and then escalated appropriately to the kind of the doctor that needed reviewing. So prior to CQC coming in and BSOTS coming through, our initial time of percentage of midwife reviews within 15 minutes was less than 50%. And it wasn't through lack of the midwives trying to get them, it was because essentially the staffing in that area wasn't safeguarded. Often if their delivery suite was busy, they'd pull from our area to cover the delivery suite area or enter inpatient area, leaving the triage department essentially shorter staffed to try and provide this timely assessment. I think there was a bit of lack of understanding in terms of the importance of that area and the importance of the reviews and the escalation process, and the need to have a triage midwife or someone triaging and rotating those patients to make sure that we are risk assessing them appropriately to be able to provide ongoing care. Our SHO and senior reviews within our BSOTS standards was less than 23% of on-time targets. So less than 23% of our women were being seen within 15 minutes, within an hour, within 4 hours. And very similar to what Ashley was saying in terms of her findings, our average waiting time was between 6 and 8 hours for a whole range of reviews, from a query UTI to query ruptured membranes, in terms of preterm ruptured membranes, and kind of more serious kind of reviews. So, women were not being escalated appropriately and weren't being risk assessed appropriately, and that care and people were then self-discharging, and that's what then increased that risk of kind of these serious incidents happening. So when I was posed with what is sweating the asset, I didn't quite understand in terms of what that kind of really meant. So I had a look at kind of what that meant. And the actual definition is utilization of structures that are already in place and extracting more value from current resources rather than trying to create new ones. So understanding that, we had done a lot of work within our triage after the CQC visit. We were looking at what do we already have in place, what can we utilize and actually extract more value from. So we moved some of the routine work that was seen in our triage, so some of the booked work that was being kind of filtrated through our triage, out back to the kind of the more routine kind of work within the clinic department. This then ensured we have 3 midwives present in triage during the busy parts of the day between 10 a.m. and 7 p.m., which seems to be a very similar busy time frame to what Ashley kind of experiences at her trust, and I'm sure it's very similar to other trusts. Utilising that expertise and the development of the ACP in the area to provide some consistency, covering 9 hours of shifts 3 to 4 times a week, and also it has kind of reduced the capacity of other medical elements to support the area. So we were encouraged to have medical coverage almost 24 hours a day within our triage. So we had to then look at our other areas and reducing their capacity to increase our capacity within the area. So when I'm not on shift, the area is supported with a doctor to cover those times. And all this has significant impact on other directorates. So it's really important to know how, if you change one element, it changes everyone else's kind of aspect of that element. And we need that further exploration into the ACP roles, which will continue, that we continually sweat that asset of utilising and future-proofing these roles and these clinical midwives who have these clinical expert knowledge that have developed them over the years, that we continue to develop these midwives and to step into these roles when opportunities arise. Because whilst we're sweating the assets of these, the ability to kind of stretch the resources, is making sure that actually we have a robust way of fulfilling these roles to equally make things run as smoothly and as safely as possible. But does all this investment improve the outcomes? And that was a big question that we had, because we're doing all this work and we're doing all these changes and stripping from different services to essentially robustly fulfill the triage needs. So we changed the structure of the midwife shifts, and separating the routine workload from the triage patients in UHD has significantly improved that initial 15-minute triage assessment time. So the initial triage review within 15 minutes was below 50%, and that was an average. So CQC gave us that target of 100% to meet. Since the CQC in 2022, the midwives' initial review is consistently meeting between 96 and 97%, which is absolutely incredible. The remaining 3% of reviews are not meeting that 15-minute time target were all seen within 30 minutes. There's never one, since October 22, there's not been one woman that's been left more than 30 minutes for initial triage, and that 95-97% has been consistent for the last 18 months, which I think is just testament to that change of structure and that kind of sweating that asset kind of around to make sure that we support those midwives and protect them in that area to provide that safety of care. So my particular data, and it's quite difficult to kind of ascertain the percentages of my reviews, because ultimately I work often 8 or 5 p.m. and outside those hours, other SHOs are not, ideally, they're meant to be present, but not always present. So the reviews can sometimes get delayed. But it's looking at kind of, we stripped out on the days that I work, looking at the hours I work. So we've kind of stripped out in terms of the percentage that we can provide, but more work has to be done in terms of being able to kind of look at this more in detail. But since I started in 2022, we've got around 17 months worth of data. But looking more importantly at the last 6 months, I have covered 12 triage shifts a month, which doesn't sound very much, but I do 4 rapid review clinics a week. So every Thursday I run a clinic who, I'll just plug myself in, obviously I haven't realised I'd unplugged my computer. So I run 4 rapid review clinics. So every Thursday I will see patients who have come in that week with abnormal scan results, high blood pressures, maybe they've had ongoing reduced fit movements that all need a little bit more of a deeper dive. That triage, you haven't got the time in triage to do. So they get brought back to my clinic and I can go through their ongoing care in a more of a timely kind of manner, and really give them a good ongoing plan of care. And those that are coming in that need a review but can't get on that day are also added to my clinic. So it just takes some of the workload away from triage to enable kind of a more deep dive for these patients to undertake. So I essentially work 12 shifts a month with 4 rapid access clinics on top of that. I've covered 60 shifts out of a possible 72 owing to annual leave, but 40% of the medical cover in triage is covered by myself. And that's either 8 or 5 p.m. Monday to Friday or 8 to 8:30 at weekends. I do one lot of weekends every month, so 1 in 4. And on the days and during the shift times covered by myself, 90 to 93% of patients were all seen within the BSOTS medical review time standards. And I know that's slightly changed, but we haven't changed it at UHD. So they've all been seen within the 15-minute, the hour, or the 4-hour mark in terms of those review standards. So I feel that's really kind of benefiting. That's pushed up, hopefully, the average of our overall medical reviews. Because since this has come in and since having those doctors, particularly in triage, the percentage of medical reviews have increased from less than 23% to an average of 74% in the first 6 months of CQC coming through, but now remains consistently around 78 to 85% of medical reviews being on time. And more, the ones out of that time are because the reviews are being done, it's just delayed, there's only that one person. But we have a really good escalation process now that if anyone is going to breach those timeframes, we can escalate to the on-call consultant if the medical registrar is unable to attend as well. So we have a really good, robust escalation process, and the consultants are all very happy to come in and step in and review the odd patient that may or may not breach if there's a possibility to do that. So hopefully that will kind of continue to increase our medical standards and medical kind of percentages meeting those criteria. But I really feel that there's been a massive inroad here in terms of consistent. It's about consistency. 1 month you don't want to hit 90%, and the next month you hit 20%. I think it's having that consistency. We may not be meeting 100% of our kind of reviews being on time, but having that consistency that's gone from 23% to 85% is really, really good starting point, and proves that having that persistent person as an ACP or an SHO in that area really helps with the flow of that patient care. As you can see, these are our medical review times, just as a bit more of a chart. You can see our pre-CQC results and post. It's just by sweating that asset and driving more kind of resource into that area really has improved the outcomes. And since BSOTS and the designated medical cover in triage, there's been no serious incidents involving the area or the ACP. I think people often ask, have there been any serious incidents involving your care practice or your decision making, and there's been absolutely zero. Bearing in mind there was 5 prior to all this coming through, so that's been, you know, a really good kind of trust in improvement. There's been no patient complaints regarding my particular care or the ACP care. There has been improved flow with reduced medical waiting times, and I think our most recent patient kind of waiting time has reduced between 6 to 8 hours to kind of probably just over about 2 hours for the whole care process. So I think we are certainly improving the patient flow and the patient times that they're in, because people don't want to wait 6 hours for care, and I think it's really important that they don't. And this has really kind of proven that. We've also reduced the delayed treatments and reviews for outpatient tests. Often we'd have all these test results that have been waiting to be reviewed, and having someone dedicated to that area can undertake the reviews of, say, MSG results that need treating, the swab results that need treating, the blood results that need ongoing plans made for, are being done in a really timely manner now, and not waiting days and days, and then they're then coming in because of septic, because they've had a urine infection that's not been treated. So I think it's kind of really kind of impacted all areas of triage care and improved that kind of the care outcome for these patients. And also it's improved that staff support through that clinical leadership and that on the shop floor job education. As morale, staff feedback and staff survey kind of has shown, I'll show you that in a minute as we go through it. So the triage staff survey, we asked them about the role kind of just about 3 months into the role as we were starting. So it's quite a new element to them. So we didn't want to ask them as it before it started. We want to ask them and see if it made any impact to their day-to-day care, and had they seen an impact in terms of patient outcomes as well. And kind of, I think we asked maybe 23 of the staff members there, and we had quite a good response rate from them. They suggested, so 17% or 85% of the staff suggest that the ACP role is a benefit to the patients and also the staff, and they would like to see more roles in this maternity unit. So they were very, very supportive over the role and could really see the benefit to these patients that were getting the care from the ACP. Before the introduction of advanced clinical practitioner role, we asked them, did they feel that the patient flow and waiting times for medical reviews were acceptable? A vast 90% of them have said no, it wasn't acceptable for these people to be waiting up to 6 to 8 hours to be reviewed by a doctor. And I think that kind of speaks volumes in terms of how the patients were feeling, but also how the staff were feeling. We also asked them within the role, was it obviously being predominantly clinical and located within triage, do you feel this role has improved or has the potential to improve your own clinical practice and knowledge during your shift? And the vast 90% of people said yes, they really felt that they felt more supported and it had the potential to improve their clinical practice during their training. So I think that was a really good kind of answer from there in terms of ensuring that actually we kind of really base this role right for them, because before we kind of assumed that's what we would be providing. But I think, you know, these are all really experienced midwives. I think it was nice to hear back from them that they really felt that they had the potential to support their own practice. And that's essentially what's really, really important. They feel supported when they're making these clinical decisions as well. Do you think this role has potential to improve patient flow and the waiting times for medical reviews? So once again, a vast amount of them said yes. The 2 that said other, they hadn't really seen the role in practice at that point, so they couldn't really comment. But a lot of the midwives were very, very confident that they had a potential to improve that flow. And I think now with the data that's proven that, I think we can show that actually the roles are very successful in doing that. So what are the potholes of healthcare, and can we expect the ACP to fill these holes? So with the ACP role, we know there's cost implications. We know that there is funding issues, and training is not a cheap kind of outlay to begin with. There's a lot of kind of cost implications for the training aspect of it in terms of your time away from the ward to your training, the actual cost of the course, And then there's the funding for the ongoing care. Obviously, the training is 18 months or sometimes longer, and it's at a level 7 master's. So obviously, it's quite an intense course. There is no quick fix, and if we want the ACP to be more sustainable, we have to look at longer term sustainable options. You know, one person is not a team, and we know that. And you know, talking from my perspective, I'd love to see more and more people coming through and starting the training for that career succession, but also providing a team of triage midwives, because I can really see how that would benefit not just triage, but ultimately kind of the clinic side of things as well, kind of moving some people around instead of having to come through the triage because they don't know where else to go. They could come through to the rapid access clinics more frequently. But obviously, the potential is there to encourage retention of midwives through career progression. I know that I was frustrated in the role that I was because I wanted to continue to progress my career, but didn't really have the options to do that because I wanted to maintain that clinical kind of outlook as a primary focus and improving that clinical leadership opportunities and clinical excellence in the area. I really feel like if you can train the upcoming midwives on the shop floor what the best practice is and lead by example, I think it's really, really important, and that will be hopefully leaving good imprints on good clinical care. And triage needs some serious funding. It's, you know, it's such an important part of maternity, but often is most underfunded or understood. We need the resource to ensure it maintains that standard of care and make sure it's being provided accurately. And the ACP role is there to ensure the area continues strives to improve that patient outcome and the experiences using those 4 pillars of ACP. And within the 4 pillars, you can really utilize all of our skills to kind of develop kind of those standards of care for those patients. So can we fill the potholes of healthcare? I'm not sure. It might just be that we try and kind of fill them a little bit, but I really feel that it is a long-term sustainable option. We're here for the long road. We don't want to leave our jobs. We want to be there providing care, but we need the funding and we need the support from our senior management. And kind of more strategically, we need the support there as well. So there's a lot of work to be done, but I really feel that working as an ACP, that we have so much opportunity and potential to really improve the outcomes of these patients that we're seeing. And I call it the ACP ripple effect. You know, we are, you know, you guys are at that starting stone point. You're dropping that stone in that lake and setting the ripples out. You guys being on this course today are really kind of looking to kind of drive that force of change of care, and you know, with that patient's perspective in your forefront. I think it's so important that you guys are here today and that we have traveled through this journey together, and hopefully longer term we're going to have more ACPs in practice with the new regulations coming through from the NMC that will provide that support for the trust to provide more ACPs hopefully in practice, and that ripple effect is going to get bigger and bigger. But it's a case of let's not make that ripple effect too big, too quick. Let's do it right. Let's learn from our colleagues in nursing in terms of racing through with the ideas of giving patient better care, but let's do it with regulation. Let's do it with good standards of practice and making sure that we are effectively providing the care within our scope of practice. Hopefully you've enjoyed kind of all the presentations today, and if you've got any questions, I'm happy to answer them. But hopefully from that you can see that we are really making inroads to the ACP role, and it is a really, really positive role to do. Thank you.
Thanks, Sam. So there's a couple of questions that have come through. First of all, I wanted to say we've had a message from Pippa Clark from NHS England, and she has said that she's happy for her email address to be given out if anybody has any queries about potential funding for the master's course itself. And so because there's the potential for funding through NHS England Workforce Training and Education. So we'll put her email address into the email that will go out with Sam's job description, the link to the recording of this webinar, and I think Romy's email address will be on there as well. But she has put her email address in the chat for me. So if anybody has a pen, it's Pippa, Pippa .Clark, CLARK 4 at nhs.net. But that will go out in the email, so that's there for anybody. Then somebody, Amanda's asking, do you get protected time to fulfill the other 3 pillars?
Yes, actually I do. I'm very fortunate that to do a day like today, I've been given the time as part of my education pillar to present today and bits and pieces of that. So I'm very fortunate. I do get some QI project time as well. So I get to do, in terms of quality improvement projects, I get time to do my a research arm. So in terms of kind of I get 4 hours a week, if possible. It doesn't sound very much, but when you queue it over a kind of space of a month, it does give us a little bit of time to kind of look at the different arms and looking at research projects, education and leadership. So yes, certainly I do get a little bit of protected time, not a vast amount, but I do get some protected time.
That's good. Sophie's saying this would make such a good presentation to do as a quality improvement example. Are you in touch with your QI team?
I am indeed. Yes, so we are in touch with our QI team, and we're going to present this with them along with a few other kind of QI projects that we're doing currently within the ACP kind of role. But yeah, I think it's really important to kind of really sing what we're doing, because I think it's really kind of made massive changes to our triage department in terms of our outcomes, in terms of just by tweaking a few bits and pieces, we've really made some big inroads to our patient care, and I think it's really good to kind of explain that and show that.
Perfect. And Hannah is asking, is there an allocated doctor that covers you when you're not present or on annual leave?
So yes, in theory, when I'm not there, there will be an SHO kind of assigned to triage, either 8 to 1, 1 to 5, Monday to Friday, and then at the weekends it's 8 to 8:30. We know those busy times between kind of 5 and 7:30 are just horrendous, but we don't have the cover at that moment, Monday to Friday, to cover between 5 and 8 p.m. in triage. So we have to kind of maintain that work between 8 and 5. Ideally, we'd have it 8 and 8, 7 days a week, but we don't have the medical budget for that. But yes, I am covered by someone when I'm not there, which continues that kind of process to make sure that our standards remain the same. But what drops our percentage is between 5 p.m. and 8 p.m. in terms of then the delays, because it goes back to the on-call team that are on delivery suite, potentially in theatre. So if we could have someone there 8 to 8, 7 days a week, I'm sure we'd hit 95% of our review times on time, but the percentages drop between those really busy times when we have less staff. I'm sure that's probably the same in every trust.
Yes,
ours.
And I think you've just sort of answered the next question, which is Anne says, you're doing a fantastic job, Sam. Just wondering what the cover would be if you were off sick. I think.
Yeah, so I was recently, unfortunately, off sick after a little injury, and yeah, it's covered by the SHO. So it is covered, like I say, Monday to Friday, 8 to 5, and the weekends also covered when I'm not there. So yeah, I think we have a robust way, but I think what would be better is if we had more ACPs in the trust. And And I think there is plan to potentially train more people. We're just looking at the ability to do that. At the moment, we've got one that's coming through that's finishing her training, but she's going to be located more on delivery suite. And that will be a development to watch, I feel. But I'm really hopeful that these roles in our trust will be developed and replicated more frequently, and we'll have more people coming through the training. We just need to get more people on it.
Perfect. I don't know whether you were actually reading the questions, but the last question on here is, are you planning on introducing more ACPs to the trust?
Oh, that's perfect.
So you're psychic.
So yes, we are. I just kind of don't know when.
Yeah. Brilliant. So that's it. Oh, one more. So yeah, Fiona's asking, what do you foresee the delivery suite ACP will do?
I don't know, if I'm honest. I haven't been really involved in her training apart from knowing her standard. So she's been going through the training in terms of looking at, she's done the happy course, prescribing course. She's been around with me in triage and in the clinic in terms of assessing patients and history taking. So I know that she's hitting those kind of set standards. But in terms of her role in delivery suite, I think they're looking at developing her doing I don't know, maybe assisted deliveries, but I'm not sure, if I'm totally honest with you, because I've not been that involved with it. But maybe that's one for an ongoing discussion on another kind of forum, really, in terms of how it's going to look, because she's only halfway through her training, and that may completely change in terms of our service needs. She may then be thinking she's going to do it on delivery suite like Ashley started, and then we'll end up doing it within triage as being part of my team, or within the postnatal kind of area, because I assist in deliveries when I'm kind of helping on delivery suite. I'll assist in the cesarean sections, but I won't do them. And I'll also review postnatal patients as well, because we do that within our triage kind of elements. So I'm also working on the postnatal ward, but my main role is in triage. And so her main role will probably may end up being triage as well, but we'll just have to wait and see where that kind of role takes us and how that will progress. But I can't answer at the moment because I don't really know. Sorry.